So here we have test question. Pause the video, take a few minutes, read this test, guess which answer is correct, and after let's discuss this test step by step. So it's 61-year-old woman with a history of non-alcoholic steatohepatitis. With long-term steatohepatitis, we always have to keep in mind a possible progression of non-alcoholic steatohepatitis to fibrosis and cirrhosis. She complains on fatigue and weakness, which are non-specific symptoms. Also, she has intermittent nausea, which in context of liver disorder can be provoked by increase in blood ammonia level, but otherwise it's a non-specific symptom. She has multiple spider angiomas, which is a very important sign, because as we know, spider angiomas develop due to the elevated free estrogens level, which is the feature of pregnancy, or this can happen in cirrhosis due to the decrease in sex hormone binding globulin. Also, she has distended abdomen and shifting dullness, which means that she has ascites. And we know that ascites develops due to the increase in hydrostatic pressure or decrease in oncotic pressure or increased permeability. In context of long-term non-alcoholic steatohepatitis, we can suppose that this ascites developed due to the decrease in proteins concentrations in the blood, particularly due to the decrease in albumins. And as we see, this patient has low albumin level. The reason is that albumins are produced by the liver. So chronic liver injury, especially if patient has cirrhosis, can cause substantial decrease in albumins production, which can cause ascites. Her liver enzymes are not significantly elevated. As we see, only ALT has mild elevation. And important that in most liver disorders, the level of ALT is higher than the level of AST, with one exception, which is alcoholic hepatitis. If alcohol is the cause of liver injury, AST is higher than ALT. But why elevation of liver enzymes is mild and clinical presentation is so severe? To explain this, here we have liver tissue with hepatocytes, and within the hepatocytes located ALT and AST. Liver injury causes damage to hepatocytes, and if hepatocytes die, their inner content will be released into the blood, including ALT and AST. This will cause significant elevation of both ALT and AST. But if patient has cirrhosis, in this case, instead of hepatocytes, patient will have fibrous tissue, and fibrous tissue do not have liver enzymes. So in this case, because patient has lower amount of alive hepatocytes, even severe liver injury won't cause significant elevation of ALT and AST, because there are no alive cells left to release these enzymes with their death. So in case of cirrhosis, no cells, no enzymes. So most probably it's exactly the reason why this patient has mild elevation of liver enzymes, despite severe clinical presentation. And now, knowing that it's cirrhosis, we can explain her symptoms. First of all, we know that liver is the major producer of proteins, as albumins, which are responsible for oncotic pressure, and sex hormone binding globulin, which is responsible for binding of free estrogens and to a lesser extent free androgens. Also, liver produces coagulation factors, which provide secondary hemostasis, and we measure secondary hemostasis by partial thromboplastin time, prothrombin time, and international normalized ratio. Also, liver provides detoxification function. Liver detoxify bilirubin and ammonia. And in addition to this, liver produces thrombopoietin, which stimulates platelets production. If patient has cirrhosis, proteins production decrease. First of all, this will cause decrease in production of albumins, which in turn causes decrease in oncotic pressure, and decrease in oncotic pressure causes edema and ascites. Also, the production of sex hormone binding globulin will decrease, which will cause decrease in binding of estrogens. So, patient will have hyperestrogenemia, and in this case, it manifested as spiderangiomas. If liver is not working, detoxification function becomes impaired, which leads to increase in bilirubin level with jaundice and increase in ammonia level with hepatic encephalopathy. Also, with decrease in amount of hepatocytes, the production of thrombopoietin decrease, which will cause thrombocytopenia. But how to explain her internal hemorrhoids and esophageal varices on apendoscopy? The concept here is that massive fibrosis in the liver tissue leads to compression of liver sinusoids with development of portal hypertension. And portal hypertension manifests as a triad of esophageal varices, caput medusa and hemorrhoids. Among them, esophageal varices and hemorrhoids can cause bleeding, but only bleeding from esophageal varices can be lethal. So the question asks us how we can prevent bleeding from esophageal varices, and as a prophylaxis, we prescribe non-selective beta blockers as propranolol. But if esophageal varices are already ruptured and bleeding is ongoing, in this case, the correct answer will be octreotide.